unite and work together if we're all going to get through this.
Sounds like socialism to me.
The amount of people I see talking about socialism positively is actually staggering.
Do you think, do you really think that a proletarian revolution is just around the corner in America?
Grab your pitchforks and stab your mayor.
Your hero, Obama.
He's not my hero.
How heroic he comes from.
If Bernie Sanders were president, right, and he wanted to bring the same ideas as for socialism into this country, do you think that we would benefit?
Yeah.
But I just told you Venezuela's eating rats.
But I just want people to have health care. I don't want,
Same thing Hugo Chavez said.
oh my god. You people have, worms in your brain, honestly.
All right, welcome to this week's episode of the Sensible Socialist Podcast, a podcast for the rational left. I'm your host, Kevin Gustafson, and this week, instead of doing the normal recap of the news, which really has basically been dominated by the wildfires in California and Alexandria Ocasio-Cortez coming to Congress and shaking things up by talking to protesters outside of Pelosi's office and other things like that. But instead, I'd rather just get right to the interview for today. Today's interview is with Mike Pappas, and Mike Pappas is a graduate of Georgetown Medical School, now a resident at a clinic in New York City, and also a revolutionary Marxist. And so Mike brings a unique but much needed perspective to medicine, and he displays this unique approach in awesome articles that appear in Truth Out and Popular Resistance. Mike is a very well-educated guy and has a very vast knowledge for a number of different things, both medicine and beyond. In this conversation, we talk about the American healthcare system, what Mike calls sick care, and about socialized medicine. And we particularly talk about his recent trip to Cuba, where he learned about more hands-on about Cuba's healthcare system. So we also discuss the effects of exploitation and alienation that defines capitalist life and really has what its effects are on the larger working class. So without further ado, here's my conversation with Mike Pappas. Mike, thanks for coming on the podcast.
Cool. Well, thanks for having me.
Instead of giving some kind of long introduction, I'd rather hear from you. Kind of just give us a background as to who you are, and I think if you can kind of take us on the story where you end up as to sort of how you define yourself politically and how you got there, and why you got there.
I am a physician activist practicing in New York City. I originally went to college in the Bronx. I lived and worked in the Bronx as a case manager for a couple of years before medical school. I went off to medical school in Washington, D.C. and did my medical training at Georgetown University. And now I'm back here in New York doing my residency training here in New York City. In terms of how I kind of identify myself politically, I'd say identify myself as a revolutionary Marxist. The reason being for that is because I think that over the years of trying to study what are the factors that cause disease both on an individual level that I see in the clinic setting, and then disease and all different types of suffering on a larger scale public health level, I've just come to the conclusion that they are systemic causes of these things, and many of them actually, in my opinion, from my analysis, stem from the way that we organize our capitalist economic system. And I think that ultimately we can train physicians, nurses, social workers, case managers, everybody in public health to address things on the immediate level as they present to them in the clinic setting. But unless we're actually trying to address things on a systemic level, I think most of those efforts are going to be pretty futile.
You're definitely treating symptoms rather than actually getting to the cause.
Exactly. And I see that all the time in clinic. There are obviously restraints put on us in the clinic setting, which I'm sure we'll get into later. But because of that, people come in and they're presenting with these complex symptoms, which are clearly a result of the environment that they're living in. And what medicine often has to offer them is like some type of pill. And I don't think that that's ever going to actually address what's really causing their suffering. And as a matter of fact, I think that by operating in that fashion, medicine really helps to uphold and continue many of the systems that are making our patients sick.
Was it in the course of the study in medicine that you like sort of became a Marxist, or were you one before you got into the medical school route? I mean, I think I have the perception, and I think a lot of people listening would have the perception that, look, a lot of people who are doctors come in, from families of doctors or something like that. And I don't think a lot of them are because of their maybe family background and their sort of class background, not necessarily going to be particularly revolutionary socialists or Marxists. And so what is the relationship between your political ideas and the wanting and the sort of movement into the study of medicine?
Yeah, so that's interesting. That's an interesting story. So I grew up in a rural part of Pennsylvania. My dad is a small business owner there. He owns a landscaping and construction company. Because of that, it was a combination of because growing up in that environment. Now, that part of Pennsylvania is predominantly white, predominantly working class. There are, it used to be, my town specifically is called Slatington. Slatington was an old slate mining town. After the slate mining industry kind of collapsed, a lot of the individuals who lived there did not have access to that type of industry anymore. I'm right next to Bethlehem, where Bethlehem Steel was. So a lot of people, my grandfather worked for Bethlehem Steel for years. So I grew up kind of in that environment, but connected to that, on my dad's side of the family, many people are very high up in the chemical industry, actually. So my grandfather was on the board of directors of DuPont. My uncle is very high in another chemical company. So I grew up in this environment of I go to school with people whose families are all just working class. My dad has this small business. He employs many people who have a history of incarceration right out of prison, graduate high school and are looking for a job, and they get a job in manual labor. So I grew up in that environment, but I also grew up with this being told, like, the typical American dream myth. If you work hard enough, you're going to make it. Look at your grandfather. This is what you're supposed to strive towards. This is the ultimate thing that you are supposed to achieve, which is getting very high up in industry. Before I actually went to college, with the idea that I wanted to practice corporate law, actually. And the reason why I said that was just, I thought, hell, I can make a bunch of money practicing corporate law. I got to school, I quickly realized that I'm not really interested in those types of things, and I'm interested in science. So what is something that can give me that position of prestige that I'm told that I'm supposed to strive for, because that's what my my family members are doing, and can also allow me to be interested in science. So I figured medicine. Medicine is a field that is revered in our society. Oh, you're the doctor in the family. So I pursued that. And I was in the Bronx at Fordham, and originally, knowing that I wanted to go into medicine, I knew that I had to get involved with community service work in some way. Right outside of Fordham's campus, there was this organization called Part of the Solution, or POTS. And I started volunteering at POTS, not at all because I thought really it was, I guess a little bit of me was like, oh, this is a nice thing to do. I'm, quote, giving back, those types of things. But it was also something that I knew I could put on a resume to eventually get into medical school. It wasn't until I really started to see people who were homeless coming into pots to even be able to take a shower, to get a hot meal, those types of things, and really started talking with people, was when I actually started to humanize people who are living in poverty, or because I'm actually having conversations with them. Prior to that, I was kind of conditioned to think, if you're living in this situation, it's your own fault, deal with it. So once I started to grapple with why there are certain people living in this environment and I'm living in the situation that I am, and I see my relatives who have vast levels of wealth, kind of what the hell is going on. I had a roommate in college whose father was a tenant lawyer for years, and he was the youngest of 5 and a completely different background than me. And he really started getting me thinking about how our entire economy works, how this capitalist system works, and told me to start reading on my own, which I never did, watching independent news media, which I never did. So I was kind of opened up to those things. And through all of that, I started to make connections between my own privilege in society, and not just that, oh, I have this privilege by some magic that I should be nice to people who don't have it, but the integral connection between my privilege and how it actually helps to create suffering in the people who I was seeing coming into pot. So things kind of took off from there.
Gotcha. Okay. And then, so you didn't, you stayed with the medical study, and obviously, you're doing residency work and stuff now. So, I do want to kind of, what I'm curious about is, I myself am a lawyer, and I know that there's a lot of, I guess in the professions, what I'm curious about is there's been every different way of dividing the working class, whether it be along racial lines or gender lines, but even in the sphere of organized labor, they've been divided based on trade or craft. And basically, there's always been this kind of distinction between the warehouse worker and the factory worker, and the doctor or the lawyer or the accountant or the, something like that, the professional trades. And there's this idea that, these professional trades are not working class people. They're like these privileged jobs. Even a lot of professionals, when I was going to law school, and I'm sure when you were going to medical school, you could just, I in some ways, like, feel the elitism of the people around you. Like, we're better, and we're something different. We have these like specialized knowledge, and that's why we deserve all this kind of money. And like, for me, I know what lawyers charge, and I know how much work it takes, and it's way overpriced. And so because they have these ideas that, like, oh, I'm not a landscaper, so I'm better than everybody else. And I wonder what you think about that, and to kind of ask it a real short way, are doctors workers?
Yeah, I mean, to answer in a short way, I would say yes. But to answer a little bit longer form, I think that I definitely see what you're saying in my everyday work, in that, and I see it actually, I think it even starts prior to getting your medical degree. I think that there are filtering mechanisms that are put in place that basically make it so it's very difficult for people to make it through to medical school. I mean, you need to get a university degree, first off. Then you need to be able to take all of the different board exams and things to actually get into medical school, which cost hundreds to sometimes thousands of dollars once you're actually in medical school to take these board exams. You often have to do all these review courses and things to actually get through it. So by the time you get into medical school, you've already filtered out a huge portion of the society. So you filter out a huge portion of the society. You have people who come into medical school with a particular mindset, and they already think to themselves, like, I work harder than everybody else. And obviously this isn't everybody, but it's a common perception among medical students and physicians. I work harder than everybody else. I've made it to this point. I deserve it. We're told that by by the administrators, by our professors, those types of things. You guys are the cream of the crop. You made it through here. You've outworked everybody else. Like it's this effort thing, not that it's you either, if you were born into poverty, somehow you got lucky to make it through, or you were afforded all of these things right off the bat that put you at advantages that other people aren't at. And then that you're just continually told that as you're going through medical school. And I think you're partly told that because you don't want to start to question, like, why am I being treated like such shit by my superiors? Why am I being forced to stand next to a surgery for 8 hours on end that I don't need to be at, and just like forced to maybe write notes that then a resident will use, do all this type of work? Why do I feel so horrible? And I think that you feel like that in medical school, but then definitely when you get to residency, at this point, you have your medical degree. Once again, you've kind of been, you've had your ego inflated. Oh, you're a doctor now. You made it. You're fantastic. So you get into residency, and all of a sudden you're working 80 hours a week. They have you seeing way more patients than you can handle. So you're providing the best care that you can provide oftentimes, but oftentimes not optimal care to each patient because your work is so stretched so thinly, and you come home, you're tired, you're overworked, and you feel like shit again. And you're just, I think part of it is telling people, well, you're a doctor, you're doing the best work that there is. Little do you know that through your entire education, and now that you're in residency, you've been conditioned to basically be exploited. And I think it's very advantageous that the power elite continue to peddle this myth to physicians that you're better than everybody else or you're different than the rest of the working class, because if physicians started to realize that they are being exploited by the exact same elite that any factory worker at Amazon or landscaper that's working for my dad, well, maybe not because it's a smaller business, but like somebody, a DuPont employee or something like that, you're being exploited by the same elite who are exploiting your labor for profit. Physicians might just start to question the system, this like profitable healthcare system that we have. And I think that that's very dangerous.
So I guess that leads me to, I have so many questions about, I think in some ways a lot of people can envision what maybe a lawyer does, right? You go through law school, you pay a bunch of money, then you work at some giant law firm doing, in some ways, there's an exact analogy where you're told, look, you all have like beat out all of these other people, and you're in, especially you went to Georgetown. I went to, a tier, well, maybe a 2 school now or whatever, but like one of the, higher schools or whatever. And they say that stuff to you all the time. Like, hey, you're, look at what you could, look at where you are. You've got all these opportunities, blah, blah, blah. And and then you get out of the school and you're working like a dog and you're treated like shit and nobody really cares about you. And you're like, you have this degree that you paid, potentially hundreds of thousands of dollars for, worked your ass off for, to go back into the point where you're the lowest on the totem pole. And at what? Like the idea that at one day you might be able to make it into like the ability to, own or something like that. I mean, it's amazing to me how much shit these people will take where they are like literally exploited and fairly visibly and easily seen, exploitation, but that they've been pounded this myth into their head that they become willing participants because, oh, well, yeah, I might work 80 hours a week, but at least I'm not working 80 hours a week at, Target, as if it's somehow any better. But I guess what I wonder about is a residency, right? Are residents well paid? Are you paid? I don't even know how that system works. Like for me, once you get out of law school, you pass the bar, you can start representing people. That's not how it works in the medical field, right? You get your degree, but then you have to do your residency, and you're paid during the residency. Are you paid like shit? Like, how does that work?
I mean, I think that you're paid more than somebody who is working, and this is by salary, you're paid more than somebody who's working like at working at like a low-paying job, basically, you're working at a grocery store, McDonald's, or something like that. You get paid a little bit more salary-wise, but when you break it down by hours, my salary is something, and I don't know the exact number on the top of my head. It's in the 60s, somewhere like that. When you break that down hourly, it breaks down to something based on the number of hours I work. I get paid around $9 or $10 an hour. So you get these jobs, and most of the time it's a residency program that is tied to some big hospital. It may be a for-profit hospital, or it may be a not-for-profit hospital, which we know operate often as for-profit entities. They just make slight changes so they can change their name to not-for-profit, so people think that they're doing better work. And you're working at these big hospitals based on the hours you work, very, very little pay, and it's hugely advantageous for these hospital systems to have residents there, because residents do a huge amount of the work in the hospital, but get paid very, very little compared to the other attending physicians there. So you bring in these residents and you say, well, we're providing a resident education here. We are an educational institution along with providing great health care. Even though we pay our residents like shit, we overwork them, we continue to try to inflate their egos so they don't realize it, and we're basically conditioning them throughout their residency to be quicker, learn how to funnel patients through the clinic faster. When you start in residency during first year, so I'm in my first year of residency, when you start in my clinic, I have an hour to spend with each patient, which frankly, I think every physician should have for every patient that they work with. They should have as much time as they need for the patient and physician to communicate about what's going on with the patient, to really learn about the patient, to really learn about the environment that they're living in, all the different stressors that are affecting their health, and actually try to come to some type of partnership with the patient to address those things. So you have an hour the first year. As you go on, in family medicine, which is the residency I'm in, it's 3 years. By the third years that I am in residency with have 15 minutes to see each patient. So go from having an hour to talk with each patient to 15 minutes to talking with each patient. And every conversation that you have is always about how you can be more efficient in the clinic, how you can get to those types of, how can you make your conversation, so it goes from some type of human connection that you're trying to have with a patient to how can you make it more efficient. So eventually, by the time you graduate, you can do it in 15 minutes. And whether you want to practice in a clinic or in the hospital, they want you to be more efficient with your inpatient hospitalized hospital patients. And I think that that's ultimately so. By the time you get done with residency and you're looking for a job, and you oftentimes haven't paid off any of your medical school debt that you're in. I'm in over $300,000 of debt just from medical school. By the time you actually get out and you have no debt paid off and you're desperate for a job, you're ready to take some position with either some big clinic system or some big hospital corporation that's going to plug you in and just make you a tool for profit production and work you until you either you just continue that the rest of your life and you develop some type of chronic illness from being overstressed, or you eventually have a break, which we can talk about this. There's a huge physician suicide epidemic. Physicians are sometimes like 2 times as likely to commit suicide than the general population. And I think that's partly because you're just overworked and you see no way out of this system.
Wow. So even, I honestly didn't know about that. So you'll have to, send me something so that I can post it with this episode, because that's terrifying. You hear an epidemic among like teen suicides because there's rising rates of depression and all sorts, and I think there's a lot of, similarities if there's a rising, rate of suicides amongst physicians. But my God, you're talking about, there's so many little feet things that you can look at that are the signposts of the degeneration of a society. And when the people who are there to treat the people who are sick are themselves taking their own lives. People who are having a Hippocratic oath to, do no harm are harming themselves to the point of, are mortally harming themselves. That's a pretty serious, I guess, just blatant criticism of the way things are. Now, do doctors? Is there any organization among? I mean, I know nurses are fairly well organized, and they're one of the last bastions of actually organized labor, and they've shown to have quite a bit of clout and stuff like that. Are doctors, organized? Because I know lawyers, obviously, there's like no organization in terms of like labor organizing amongst, associate attorneys or something like that. Is that the case for doctors? Is there just nothing that doctors have in terms of an organization that they can go to?
Yeah, so that's an interesting question. Before directly answering that, I would say that to try to answer it, there are some resident unions and some efforts at unionization going on, but I think that comparatively, when you compare physicians organizing themselves compared to nurses, I don't even think that they even are close. They're not even on the same planet. And at least in the United States, when it comes to organizing. So I think that's partly because what we had talked about and what you had mentioned, what you hear, when you're going through law school and when you get out, and what I have heard going through medical school and once I get out. And there's like this, I think this like hyper individualism and elitism that gets kind of like injected into your thinking as much as it possibly can. So by the time you get, and it's like this hyper individualism and like this savior complex that physicians have. So instead of, which we can talk about other healthcare systems, like the healthcare system in Cuba, which I've studied a decent deal. And instead of kind of focusing physicians in a way that you are partnering with the community, you're a member of the community, you should want to live and work in the community that you're serving, the patient that's presenting to you knows themselves best, you are just one piece to caring for the entire health of this patient and community, and you should want to work with community organizations and with other members of other fields to provide the best healthcare possible. I think physicians are often like provided this idea that, well, I'm the physician, I know what's best for the patient, and yeah, I'll take the patient's opinion, but I'm still the physician. I've gone through all this training, and I can definitely address all of these patients' health issues. Like, we are never just told our healthcare system is, I would say, to be frank, shit compared to other countries' healthcare systems, and to accept that, and to accept that the healthcare system is not and cannot provide these things for various reasons. So we're taught that we can definitely address all these things. So by the time you're working in residency, or you're working at wherever you're working outside of residency, you've been taught to have this like individualistic savior mentality, which makes you, I think, much less likely to want to organize and work with other members of your field. And if you so you sit there, you're not organizing as much with members of your field, and then in residency, for example, your work so much and the hours are so just grueling that oftentimes people are just, by the time they get done with work, focusing on having some type of meeting afterwards is one of the last things that they want to think about. They just want to go home and sleep, so they're much less likely to think about this. And you, by being told consistently that you made it, you're one of the MD, you're less likely, as I've said, to think that you are, or to want to accept that you are being exploited, and then actually do something about your exploitation. And when you have $300,000 or whatever, $100,000 of debt looming over your head, and you're just trying to make it through residency and make it into some job afterwards to pay off that debt, it's very threatening to a physician to say, wait a second, let me organize against my exploitation, because you just want to make it through to pay off your debt. Now, there are there are some, there's like a union for residents, for example, called CIR, Committee on Interns and Residents, that is supposed to be a union that's supposed to support residents and help them fight against these types of things. And I mean, maybe in some settings they do a little bit more work to actually like mobilize physicians. But I would say at least thus far, the types of conversations that I have had with the union entities in residency have been like very, very, very disappointing. It's like typical elite union leadership that the residents aren't like actively involved in. They'll come to at least my residency and quickly talk with us about like, hey, how are things going? And not really help us organize, not really push us to actively organize in a more radical way. So, I mean, just one quick example is we had a meeting the other day, and in our clinic, people always get extra walk-in patients put on their schedules, especially third years. Third years are overworked, they're tired. I bring it up with the union to kind of point out like, hey, how about we organize around this right here against our clear exploitation and say, we don't want to do this anymore because it's actually harming the care that we're providing to people. And the best thing that the union had to offer was completely deflecting that conversation and talking about how they have organized residents to fight against burnout by not doing work that's, quote, below their pay grades. So not scanning paperwork or not taking blood draws or those types of things. And that is the best way to fight against the resident exploitation, is to do something like that, which really what it does is it again separates us from the other individuals who are exploited inside of our healthcare system. So if you operate in that manner, I'm thinking then, I don't want to do work below my pay grade. The nurse should do this, or the desk assistant should do this. So all of a sudden, everybody who's exploited inside of the healthcare system is fighting against each other instead of working together, realizing that they're all being exploited for profit. And the last thing that I would say is the thing that happens very, very often in medicine that I've seen thus far is to be frank, patients are held as hostages against the organizing of physicians. So if a physician is going to try to, or a group of physicians are going to try to work together to maybe like strike or to withhold their labor in some manner, there's always this rhetoric that is used that, well, if you do that, then patients are going to suffer. And you really shouldn't do that because then you're going to harm the health of patients even more. There's no kind of grappling with the fact that our healthcare system is literally killing patients because we are not actually, it's not even a healthcare system, it's a sick care system that's based on exploiting patients for profit. But there's no conversation of that. Instead, physicians are just threatened to say, well, if you guys try to actually organize against these types of things with your patients, on behalf of your patients, you're going to harm them. So you should probably just shut up and continue with what you're doing.
God damn. So, yeah, I mean, it's like a perfect argument as to why you can't do it. I mean, the grand irony of it, of course, is that if you had less overworked doctors and more resources available for patients and more time to deal with patients, what you would have is not a decrease in your patient's health, but an increase. But it's the same standard argument that you'll hear at Tesla or at Walmart or any place that has, doesn't want people to unionize, is that the idea is that like, you're going to suffer, or the thing that you're doing is going to suffer if you do it because you're going to have to spend all this other time doing union stuff and paying union dues. And the grand irony is that when people, it's rather obvious, but sort of shown scientifically that if people care about what they're doing, they do it better. And so if you give people any investment in what they're doing, they're going to participate in a way that's much more meaningful than if they're just punching a clock. And if they feel, especially residents, and I'm sure, doctors just coming out of residency, there's just immense pressure to, pay off the bills and in some ways maintain the lifestyle, right? You're a doctor, you have to do all these things. And there's all kinds of obligations that I think what you were saying too is that it's a pretty easy thing for owners to do to prevent organizing by simply overworking their workers. And I guess, is there some exception to like labor law issues? I mean, are there like labor law violations where you're having to like, stand and do things at intervals that you wouldn't be allowed in, say, an industrial setting because it's a medical setting? And I guess I would want to just kind of segue that into maybe talking about how the healthcare system sort of actually works. Doctors are, I guess, employed by hospitals. Who owns hospitals? You said you've kind of said that they're owned by corporations, but I'm kind of wondering what the relationship is between these big business medical corporations and the whole insurance industry, because that is a difference between, say, lawyers and doctors. That there's no like legal insurance industry because it's not like this. There's not this obligation there's no obligation that everybody gets a lawyer. There is kind of, but it's not the same as the doctor. And so there's this whole insurance field. And so I wonder if what are like what is the way that the system actually works, because it's always been confusing to me. And there's whole people with careers about filing insurance and the complex and the relationships of like Medicaid, Medicare, and all that kind of stuff. And so I guess lead us into that discussion, because I need to be educated on that.
Mm-hmm. So I guess to comment on the labor law portion of that question, at least from the kind of research that I've done into it, it seems like because residents are salaried, that the hour limitations and those types of things don't, they can somehow, since they're salaried and since it's deemed like an educational endeavor, there's some way that they're able to skirt around any types of laws around work hour requirements and those types of things. And there are groups that help to kind of govern a lot of this graduate education and how it functions. So I'm talking about residency specifically right now. One of which is called the ACGME, Association for Colleges of Graduate Medical Education, or something along those lines. And there used to be a work limit that they put on the hours that residents could work. And because they were noticing that there was this physician suicide epidemic that was happening. And this isn't just residents, but residents were jumping off of the buildings of like the roofs of hospitals. And they were wondering why these young physicians were doing this. How could they address it? How could they address how much people are overworked? And they said, you know what? We need to try to limit the amount of hours that people work. That way they can somehow like have more balance in their lives and try to do things that they actually are interested in and love, and hopefully then they'll be able to provide better care to patients, and they'll be happier, and they won't be jumping off roofs. And they came up with this grand idea to limit work hours at 80 hours a week. That was their way of being compassionate to physicians. And I wrote a piece recently called Capitalism is Killing Patients and Their Physicians. And in it, I quote one of the higher ups in the ACGME. And basically what she said was that physicians kind of need to get used to this. They're going into a field where they're going to have to work long hours, and they're just going to have to get used to it. You can read the quote in my piece. I'm just going off the top of my head, but that's basically what she said. So we limit work hours at 80 hours a week, and then we wonder why physicians are 2 times as likely as the general population to commit suicide when we're having work 80 hours a week. And those are 80 hours a week that are actually logged. So a lot of times, if you log more than that, the residency program will tell you, can you change how much information you logged on the website, because it's going to harm our residency program, and we're really trying to do the best job possible. We're just like, it's difficult for us, which it is difficult for them because the ACGME doesn't care. So they put in policies that they they pretend that they care, but they really don't. So it makes it difficult on the residency to follow the requirements from the ACGME and from those overarching organizations, but also actually like limit your work hours. So, but they ask you to change your hours that are being logged. So you might be even working more than those 80 hours a week as is. So, I mean, I would say that's part of the issue here when it comes to like the labor laws and those types of things, based on it being having the title of an educational endeavor and being salaried. It makes it so somehow they can kind of get around those things.
It sounds like internships, you know. I mean, it's the same kind of principle of like an intern, right? We don't have to pay them anything, and even though they're working, and the labor laws don't apply because it's quote unquote educational. You know, it seems like the same kind of thing.
Yeah, so that's what and really while they're doing that, then they give you a small salary compared to the amount of like work that you're actually doing, and they have you they work you as much as they can while you're in the hospital and tell you only the strong survive, and just keep your head down and funneling patients in and out of your clinics and the hospitals do things like they say, get patients out before 12 p.m. if you're discharging them. It's best for patient care, and make sure that they're discharged before then, so there's people waiting to get into the hospital. Really what they do is they overpack the ERs. The ER at the hospital that I work at is so crowded that people can't even walk around it. So they overpack the ERs. They don't want to expand them or pay to have the ERs expanded or pay for more staffing, because obviously that would impinge on profit accumulation. So they just overpack the ER. They have people lined up ready to be admitted the second that you get somebody out. And they want you to get them out so you can funnel somebody right back into that bed, and then get them out and just keep going with that process. We don't actually care about what's going on in that patient's home situation and how to make sure that the ACA is trying to impose some of those things to make sure that they don't come back to the hospital, but it's really just get people in and get them out. Now, to talk a little bit about how the healthcare system functions, in the United States, we have a market-based healthcare system. So our system basically and like I said before, I would call it a sick care system. I wouldn't really call it a healthcare system. And what I mean by that is with our healthcare system, we wait for people to get sick and then present to our clinic or the hospital or you name it. And then we care for whatever illness they're presenting with. And then we send them out on their merry way. And we wait for somebody else to get sick and present to us. So we treat these illnesses as they present instead of really in a robust manner. There are some efforts to do this, but in a truly robust manner, trying to prevent disease by actually looking at the systemic causes of disease, which we can kind of go into later. Our system spends more per person on healthcare than any other nation on the planet. And even after the Affordable Care Act or Obamacare was implemented, we still have 29 million people who don't have health insurance. So when it comes to health insurance, we operate in a fashion that we have the public systems, which are, Medicare and Medicaid, which either if you're elderly or have certain qualifications in the former, or you're under a certain income bracket in the latter, you can qualify for those two things. But other than that, you often get healthcare either from your employer, if your employer offers healthcare insurance, or you get healthcare insurance from you pay for it from a private entity. There are health insurance companies which are operated most often in this capitalist manner, which I would define capitalism like basically by the relationship between employer and employee, and they're operated by like a small board of directors and minority shareholders that kind of operate these health insurance companies. I think it's like just a couple health insurance companies, like 4 or 5 health insurance companies control around 40% of the market of providing health insurance in our country. And even with this, we still have, like I said, 30 million people who do not have access to health insurance. So you have these health insurers which ultimately have the primary goal of generating as much profit for their minority shareholders as possible, but they're supposed to be providing, basically paying for health care for people. So they're constantly scrutinizing and trying to reject the insurance claims of people for when they're sick. So you have providers who, even in my clinic, and I work at a federally qualified health center, but in the clinic settings, you're spending a lot of time like filling out paperwork to make sure that this insurance claim will be reimbursed. And when you see private healthcare providers, they often have to employ individuals or multiple individuals just to do insurance claims and make sure they actually get paid for the work that they supply. Then when it comes to the hospital organization, you have big hospital corporations that, again, often operated by a board of directors, a few wealthy shareholders that make decisions about how things go on in the hospital. Then you have the employees who are working in the hospital setting, who are bringing patients in and out of the hospital. And I would say that many of times, though these hospital corporations and clinics say that they're trying to provide the best care, patients are also seen as basically chips in this game to accumulate as much profit as they can. So I think that's kind of like how our healthcare system often functions, with these private companies that are dictating how care is provided, which, as we can see by our health outcomes, I think the United States is ranked with something like 30 or in the 30s by the WHO for efficient provisions of healthcare. Clearly, the way that we are organizing our healthcare system isn't working for patients.
Yeah, so I guess that's a perfect way to. There's been a lot of talk, obviously, at the suggestion by Bernie Sanders and Alexandria Ocasio-Cortez and others, for a Medicare for all system. It's been talked a lot about. I think the people who are listening to this podcast will have a decent idea of what that sort of means. But if you could, this is where describe, the way a socialized system works. And I wonder if, there's like single payer systems, there are other kinds of socialized systems. And so I wonder if you can maybe talk about socialized systems, and specifically kind of lead that into a discussion of Cuba's healthcare system, because as much as one can recognize particular problems with Cuba and its and things that's different issues with Cuba, healthcare is not one of them. There's no one in the world who can really contest with the idea that Cuba's healthcare system ranks among the best in the world, and it sends its doctors all over the world. And so, what is it about the Cuban system that differentiates it even from other socialized systems, and what lessons can we learn from it?
So, I guess first to talk about single payer system. So in a single payer system, and this is like often what Ocasio-Cortez and Bernie Sanders are kind of talking about when they're talking about pushing for Medicare for all. And I'm part of organizations. There's a great organization that's pushing for this called Health Over Profit for Everyone, or the HOPE. And for people who want to learn more about the differences between different bills and things that are being proposed, going to HOPE's website is somewhere where I direct you. But basically, in a single payer system, typically the government will replace insurance companies as one single insurer. So you will have basically the government is the single insurer. Everybody qualifies for this insurance just as a basic human right, right off the bat. But there are positives there in that. Let's talk about the positives there. administrative costs in our system have continued to climb because you have these current private healthcare insurers that are trying to produce as much profit as possible. So they're continually have to pay for all these administrators to try to reject claims and find different ways that they can increase their profits. And what we see is that administrative costs in our healthcare system have really doubled since 1980. So a single payer system would cut much of these costs because you would have one single payer actually just not continually trying to reject claims. It's in the best interest to make sure people are as healthy as possible, so they are not continually going to the doctor and trying and using healthcare dollars. So it's a preventative medicine model in that sense. So a single payer system would have advantages in that way. The one thing about that is the delivery of the rest of the healthcare in many respects is still in private hands. So when it comes to the pharmaceutical industry, for example, or when it comes to all of the discussion that we had just had about these private hospital corporations and those types of things, those would still be in private hands. And I think that many times in the United States, because of all of these myths that we've just been conditioned to believe about how the capitalist system pushes for competition, and that is the best way to drive innovation, and it's even in our healthcare, competition is the best thing possible, and it'll provide the best healthcare for everyone, which clearly by our healthcare system's results we're not seeing. Right. There's a lot of this talk that we would want to keep these, whether it's the pharmaceutical industry or whether it's hospital corporations, in private hands. And I think that people push for single payer system because it's almost like the most reasonable thing to get everybody healthcare in our society, while also somehow not pushing for nationalization of all of these other industries, which people would be all up in arms about. So
taking understanding that, I'm not sure, I don't know if you consider yourself an expert on healthcare systems, but is that the more Canadian style system? I mean, is Canada a single payer system that has like private hospitals and private pharmaceuticals, which is maybe something different than England, which has the national health system or service? And so is there, do you know of an example of like a really just like a single payer system that is really just a government paying private hospitals? I mean, is that Germany? I really don't know.
I think Canada is an example of a single payer healthcare system that, I would argue works much better than what we have here. There's all of this talk. If you flip on, anywhere from Fox News to CNN, there will be talk about long wait times in Canada and people can't get what they need and those types of things. And I actually don't think that there's much data to support almost any of that. I think that people get the care that they need there, and it's a system that's structured in a single payer model. The comparison that you made, I think, compared to a nationalized system, an example of that would be a system like Britain's National Health Service, that basically in the 40s, they nationalized their health service. They basically put all hospitals into public ownership, and doctors are employees of the government there. So it seems like that's kind of a step further than what we're even advocating for here, which I'm a proponent of single payer Medicare for all. That's a step further than that, which would be nationalization of the hospitals, and the doctors wouldn't be employees of the government. Frankly, I think that we need to even go further than that, which would be, I think we need to nationalize the entire pharmaceutical industry. I think that we see all the time the pharmaceutical industry anymore, new drug production is only around drugs that they know will have a huge bang for their buck. And there's all this talk about, well, they need to get a huge bang for their buck because they put so much money into R&D. And that, I mean, a majority of the research that goes into pharmaceuticals in this country is actually publicly funded. So it's publicly funded research that then, because of acts like the Bayh-Dole Act, which I forget the year that was passed, but it actually allows then private companies to buy the rights of that research to then use it to develop whatever drugs that they want. So these companies allow taxpayer money to go into researching different therapies. Once taxpayer money does all of the preliminary research, which is a huge amount of the actual research that needs to go into producing the drug, then the company buys the patent, buys the rights to it, and then they say, oh, look at us, look at all the innovation that we've done, look at how fantastic we are. And so I think that nationalizing whole systems like the pharmaceutical industry would be hugely advantageous to the health of our entire population. Now, to talk a little bit about Cuba's system, I think it's very different than even Britain's system or Canada's system. While I think that both of those systems are much better than the U.S. system, I think Cuba's system is different, and it's important to talk about that. And I think one good place to start with that is, during the revolution, or after the revolution, Che Guevara, who was a physician who trained as a physician, eventually was obviously hugely integral to the Cuban Revolution and then in the Cuban government and those types of things. He wrote a piece called On Revolutionary Medicine. And I think that piece is what Cuba's healthcare system was tried to model itself after, many of the points made in that piece. And I think that some quotes from that are interesting to kind of examine when looking at their healthcare system. And what he said in that piece was, the principle upon which to fight against disease is the creation of a robust body. And then he goes on to say, not just the creation of a robust body, it's the creation of a robust body with work of the whole collectively upon the entire social collectivity. And he said, in developing their healthcare system, medicine will have to convert itself into a science that serves to prevent disease and orients the public toward carrying out medical duties. And medicine should only intervene in extreme cases where it's needed. I think that those ideas of actually creating an entire robust body inside of their society that tries to prevent disease from the get-go is something that when examining Cuba's healthcare system, it appears that they really try to do. So in Cuba, everybody has a right to healthcare. That's number one. Some of the principles of their healthcare system are, it's a right available to all. It's free of charge. Healthcare, they think, is the responsibility of the state. It needs to be preventative, and curative services need to be integrated. The public actually has to participate in the healthcare system's development and functioning, which again is very different from the United States, where we just say we're the doctor, you listen to us. Healthcare activities need to be integrated with economic and social development, and then they have a big global health component. So what you see in Cuba is you see physicians who are actually based in the communities that they serve. So physicians are there. There's whole teams that are there to actually care for like small sectors of the community. So there are physicians there, there are nurses there, there's like other like social type workers and those types of things, so who all work as a team to address the health of a community. The physicians actually spend time going out, doing home visits. They're required to do home visits a certain number of times a year. They go and actually see their patients in the home. They try to address illness that's brewing prior to it actually happening. So if there are any natural disasters or anything like hurricanes and things that are coming, you see much lower death tolls in Cuba because physicians are actually going to the home and saying, okay, what do you need here? How can we help you? What are the risks that are here to your health? How can we address this before it actually happens? Being that they actually, especially because of the special period, which was a period when the United States really tried to criminalize Cuba after the revolution and cut off ties to Cuba to other parts of the world, and after the collapse of the Soviet Union, Cuba had to really put money into its healthcare system. So they actually trained physicians free of charge there, and not just physicians who are Cuban. I have friends who were born in the United States and went to Cuba for a medical education. And there's a school they have called the Latin American School of Medicine, ELAM. So they provide a medical education, which I would say is a much better education than we receive here, free of charge. And then their only requirement based on that education is you need to go back and serve they say an underserved or marginalized community in your home country. So physicians can actually get a medical, they encourage people to get a medical education because they see providing good healthcare as a public good. They want more physicians to actually be caring for people, to be stationed in communities and know their community. And even, nurses, physicians might fluctuate a little bit from the reading that I've had in my time in Cuba, what I garner from talking with physicians. But nurses are often in the same community for years and years. So you know the community well there. They invest in that. And they don't charge for their medical education because they want more and more people to get it because they think that it's a public good. So I think that there's a much different mindset around disease, how to address disease, the different factors that contribute to disease in Cuba as in comparison to somewhere like the United States.
So have you been to Cuba?
Yeah. So actually, before I started residency, myself, another guy who I went to medical school with, and two of my friends traveled to Cuba for a little bit less than 2 weeks, and before going there, had reached out to scholars who have studied Cuba's healthcare system in depth. We reached out to physicians who are practicing in Cuba. I reached out to my friends who trained at the Cuban at ELAM, and to try to make some connections of things that we could see while we were there. So while we were there, we spoke with physicians who are practicing in different communities, both on a clinic level and in the hospital level. And then we also had meetings with members of their health ministry. So we had a meeting specifically with one of their executive, one of the higher administrators. His name's Dr. Ochoa, and he gave us a whole kind of presentation of how Cuba breaks down its healthcare system and how there are different tiers of providing care and how it tries to prevent disease prior to the disease actually arising. And they also talked to us on the flip side of that, how much the U.S. embargo trying to demonize what I would say is a state that had the audacity to push back against U.S. empire and hegemony, how that embargo has actually affected the Cuban healthcare system over the years, and both on some level forced them to integrate, on another level made it even more difficult for them to provide healthcare to their population, but also on a level that many people don't hear about is it has actually harmed the health of people in the United States because Cuba has innovated and created lung cancer vaccines and these types of things that the people in the United States don't have access to because of the embargo.
So the grand irony of that is the Cuban healthcare system, despite its restrictions and inability to trade with and consult with what let's say publicly funded research and development that is being done here are not able to, because I've heard things like is it lung cancer? There's treatments. I guess maybe motivated by the fact that, it is Cuba, right? They like their cigars. But there's I'm not sure what exact treatment it is, but it's a treatment that essentially, because the embargo is unavailable in the United States. and could help a lot of people who are suffering, the effects of cancer, because of, at this point, chauvinism. I mean, I think it was just recently that the UN General Assembly again held the vote, which they do every session, whether or not the United States should end the embargo, and it was everybody against two, the U.S. and Israel.
It was 185 to 2.
Yeah. I think up to this point it's like 190. It was like 190 to 2, which is pretty bad.
It's there. So yeah, I mean it's ridiculous. We'll just say that. But there is the one of the therapies is a lung cancer vaccine for certain types of lung cancer that they developed that we don't have access to here. And that's just one example. The other thing that I would say is innovative about Cuba's healthcare system in comparison to the healthcare system in the United States is that communities actually have integral input with how healthcare is provided in Cuba. So they actually put like an emphasis on having community input through these different popular councils and things that they have to actually have an input in how healthcare is provided. So it's a much more dynamic system. So community members who are actually seeing what is happening in my community can not only just mention it to their doctor like we do here, but they actually can have an impact on then how healthcare is provided or how public health measures are implemented in their community. So it's this dynamic model. And I would say that an example of this that somewhat existed and we still try in some sectors of our healthcare system to implement in the United States is when you look at how the Black Panthers and the Young Lords tried to actually have communities take control of their own healthcare. So, for example, the Young Lords, when they were, and this is just like direct healthcare, but we can go into also public health measures. But when the Young Lords were like in the 60s and 70s, they were training women to do their own gynecologic exams. Wow. So it's basically, if a healthcare system functions correctly, we should want to make it so eventually my job is obsolete.
Right.
So eventually the public can take care of their own healthcare. The Young Lords were talking about air pollution in the Bronx. They were taking TB screening vans, taking them over and actually driving them to the communities that needed them because the communities were saying, we need this type of screening here. And I think that comparing that to Cuba's system, it's like they can react much more dynamically to the issues that are presenting in a community because the healthcare system isn't just focused on how it can extract profit from each patient as much as possible. It's how it can, in the best way, provide care to patients. And if that is changing things in a dynamic way, then that means changing things in a dynamic way. There have been multiple evolutions of the Cuban healthcare system over years since the revolution. And the other thing that I would say is, and I would say that the Cuban government and the Cuban healthcare system does this on a particular level, is you don't see in Cuba, all of this like push around privatization and those types of things doesn't happen like it does here. So we have a huge housing crisis in the United States. We have millions of people who are out of their homes. In Cuba, it is a human right for everybody to have access to housing. And people can even, at least from talking with their public health officials, what happens is after people work a specific number of years and they are providing it's a sliding scale model of a percentage of their income to the government, they just own their house. They own it indefinitely. And there's no more, there's not this like renting from a wealthy landlord. And then if you lose your job, all of a sudden you can't pay your rent, you get kicked out. Or if the banking industry collapses our economy, you can't pay your rent anymore. You just lose your home.
Yeah.
So I would say that is a way of addressing the public health of the population because people have a place to live. They have a community that they're connected to. The other main point that I would make is the vast levels of wealth inequality in Cuba. I would say is another, the vast levels of wealth inequality that don't exist in Cuba is something that can starkly contrast with the United States. Here in the United States, I mean, what is it? It's like 8 people. I think it's like now 8 people own more than 50% of the world's population or something like that, right. 8 billionaires.
Yeah.
And I think it's something like in the United States, 2/3 of our population couldn't cover like a $500 medical expense. So not only do you see the chronic stress because people are continually driven into poverty and exploited in their workplace and those types of things, which affects health, but just those vast levels of inequality and actually having control over your own life affects your health. So there were these interesting studies that were done called the Whitehall studies in Britain. They were in the 60s. Whitehall 1 was in the 60s and Whitehall 2 was in the 1980s. And basically they screened a huge number of people in their civil service industry. And the way that worked is those people are basically, they were paid on certain like gradients of pay scale. So you could see like stark differences in pay scale among people. And the Whitehall studies just wanted to try to identify early causes of cardiovascular disease and death in people. And what they ended up finding in these studies is the lower your employment grade, the higher level of mortality that you had. And that was it was actually in a stepwise fashion that they saw that in Whitehall 1. So they did Whitehall 2 and they were like, well, what the hell is going on? Why is this happening? And what they found was that the causes and the differences in mortality, the largest contributing factor to that was an individual's sense of control in their workplace and in their life. So if you relate that to what we see here in the United States versus what we see in Cuba, people feel like in Cuba they have much more control over their lives. They're not like struggling to pay rent and those types of things. Whereas here in the United States, people, because of the capitalist way of organizing the workplace, people don't feel like they have control over what they're doing in their workplace. And you can even relate that to, me practicing as a physician, or you name the workplace, and they don't feel like they have control over their own lives. So that inevitably causes chronic stress and leads to disease. And I would say that Cuba is addressing that in a much different way than we do here in the United States.
So that perfectly leads into what I wanted to kind of go into, which are the things that you were really talking about. I mean, you had sort of mentioned before that there is very much a symptom following and treating symptoms, and just does your back hurt right now? All right, we'll give you painkillers because that'll make it, the pain worse or, less. And so that'll give you some time to figure it out or something like that. That there is this there isn't a holistic view of medicine. And I wonder, I mean, just recently, Sam Harris had on Johan Hari, and he has a book on depression, saying setting up the same thing that you're talking about. This lack of ability to have control over one's life is it's amazing to me that it's in some ways like this surprise to find out that it has all these dire consequences, because it seems rather obvious that the farther away you pull someone from the having purpose, the further more dehumanizing that you're doing to that person. You are taking away that person's sense of being. And I think I wonder just sort of how deep is this. Is there any movement to recognize the larger consequences of the system on the healthcare system, or has it been so incredibly captured that there's really just it's it's still very much just knee jerk and not taking into account the other factors like housing and the wage is inequality, all of those kinds of things that that obviously contribute to a person's both mental and physical health.
Yeah, I'm starting to echo. I don't know how to fix that. What I would say is that I wouldn't call it a movement to start actually addressing the larger systemic issues that are actually causing suffering and disease. I would say that there's all this research out now where it's like the obvious thing that people have been saying for years. Now that we spent this time to do these studies, people are like, oh, there's this research out that shows. So like there's the adverse early childhood experiences study, or the ACEs study, which shows that, kids with adverse childhood experiences are more likely to have all these different mental health issues and disease as they grow up. And I mean, that's something that is blatantly obvious to anybody who just looks at it and thinks about it, but we've already did a study on it. And now we can say, all right, well, we got this study that shows this. And it's starting to be talked about in medical school more and more. And what we always talk about is the quote, social determinants of health is like the buzzword in medicine now. You always got to make sure that you focus on the social determinants of health when you're in clinic. And frankly, I just think it's, pardon my French, just a load of bullshit. I think that we just, like in medical schools, like we peddle that more and more and more, but there's no discussion about, one, why we can't actually address the social determinants of health in the clinic setting, why our healthcare system doesn't want us to address the social determinants of health and will not actually provide for people to address the social determinants of health because it exists and continues to churn things the way it does off of people staying sick and coming into the clinic and being sent out and coming right back in. It is not a preventative care model. So we don't talk about how because of the way that we structure our economic system, we cannot actually address the social determinants of health. So instead, because that's very uncomfortable for us, I think, as physicians who just want to be like, here's the solution, take this pill and call me in the morning. Instead, we just say, you got to address the social determinants of health. And we leave it at that. Maybe we'll have a few lectures about it in medical school training. And then maybe there are small sectors who are doing it a little bit better than others. So for anybody who's involved with the medical field, I would encourage them to look up Florida International University and the work that they're doing there. So they do things a little bit better in certain sectors, but as a whole, there's no mass movement to actually address these types of the things in the healthcare system. I would say that what we need is, I wrote a piece for Truthdig a while ago called On Revolutionary Medicine. And really what it was examining how, whether it's in the clinic setting or in healthcare, we can actually work with our patients to make connections between these structural factors that are affecting their health and whatever presenting symptom that they're coming in with, and then how we can connect them with larger organizations that are actually resisting these things. So to give one brief example of this, I had a patient come in the other day, and his presenting complaint was, I got a bunch of anxiety that I'm dealing with, and I've been feeling depressed. And this was actually when I was shadowing, before they let me go in residency, I had to shadow another more senior resident. So he's presenting with this issue, and we have these scoring modalities in medicine where if you check off a certain number of boxes, we've just diagnosed you with anxiety disorder, or we've diagnosed you with major depressive disorder. And our medicine solution to that is Well, anxiety disorder, let me connect that with giving you an SSRI or giving you whatever type of medication that we've deemed, which by the way, the data doesn't support all that much that they actually work, but that we've deemed is what we should give you for your anxiety or depression. And then we'll send you out on your merry way. I think that there are a few problems with that. One, this individual, when you talk with him a little bit more, what he expresses is the reason why I'm feeling anxious and depressed is that I just lost my job. I am struggling to maintain my current job. My wife is out on disability right now. We have 2 kids. We're having trouble paying our rent. I'm afraid that I'm going to lose this job, and I can barely make rent as is. We barely can put food on the table for our kids. And that's why I'm having anxiety and depression. Now, what medicine does is we say, okay, all of that you're feeling is abnormal. This is a normal thing to feel. So let me give you an SSRI, which will make you feel normal, and come back in a week or 2 and we'll see how it's working. I would argue that what medicine needs to do is understand that, A, what this patient is feeling is absolutely normal. It's an absolutely normal response to a sick system. And not only do we as providers need to recognize that, but we also need to tell our patient that. We need to normalize it for the patient, say, this is an absolutely normal response to a sick system. This sick system is making you feel this way. And if you want this SSRI, okay, fine. We can talk about whether you want a medication for it or not. But let's have a discussion of first off, let's have a discussion of all of the strengths that you have for being resilient in this sick system. So empower the patient to actually feel good about surviving inside of a system that is meant for them to fail and meant for them to feel this way. That's 1. And 2, what are some ways that not only can I help you recognize that this is due to a sick system that you're living inside of, but what are some ways that you can actively address it? So is there a union at your job that you can get involved with? Is there an organization? Is there a tenant organization that you can get involved with, or in your area that's working to keep people from being pushed out of their housing? What are these things that you can get involved with to actually fight back against this system, that we can have those conversations in the medical setting? And I would say that we do not do that now, but it would be a much better way to actually approach providing healthcare than the current model that we have.
Yeah, it amazes me, essentially what you're talking about is like prescribing activism rather than, than psychotropic drugs or something like that. I mean, but the thing is, really what that is a prescription for purpose in purposeless, in a system that makes people purposeless. And I think it's amazing to me how that it seems so obvious to me when you say it, and I think that it boggles my mind that we just deal with the fact that we have a system that we know is broken and know isn't doing these things, and just don't care. I mean, do you have any concerns about, we're looking at a serious economic collapse, in the next few years probably, and there's obviously significant health consequences when an economic crisis hits, and if there is not the kind of political fortitude to be able to maintain the system, and you have a significant collapse that's even more like the depression. What do you have concerns about the consequences of even that, and going beyond that, even something like a breakout of some 1918 flu kind of epidemic or something that could really the fact that the system is so broken now that would just be so overwhelmed and unable to deal with that it would lead to ultimately lots and lots of preventable deaths.
Oh yeah, I mean, I absolutely have a a huge concern about that. And I don't think that our healthcare system, when we see that happen, which at this rate is inevitably going to, I mean, most major economists are saying within the next, I forget what's the number, like 5 to 10 years for sure, we're going to have another collapse, which as we've discussed in the past is part of the cycles of capitalism, and you have those collapses built into the system. But as that happens, I mean, I don't think that our healthcare system is built to address that. And you see, I mean, look at what we see right now. All the numbers on the media are like, the economy's doing great. More and more people, like the unemployment rate's going down, and those types of things. And really, like when you look at it, and Richard Wolff talks about this all the time, is like when you actually look at how unemployment statistics are calculated, once people stop looking for a job after a while, they're no longer counted. So more and more people are feeling so screwed that they've stopped looking for jobs, but the numbers look better and the stock market's up, even though it's something like the top 1% own like 75% of the stocks or 80% of the stocks or something like that. So really that means nothing for the general population. So you see all this already happening. And I see, you know, I mean, where I work in the Bronx and I work in Harlem. And you see just the other day, literally just the other day, I had a guy come in, a grown man in the ED, bawling, crying because he watched his best friend of 30 years overdose on some laced opiate and feels guilty about it and couldn't do anything about it after they were living on the streets for how long. And you see this opioid epidemic, which was largely created by families like the Sackler family and those types of things, combined with the despair created by the capitalist system, pushing more and more people into poverty. And I only think that with another economic collapse, that's going to increase. We're only going to see more of that. We're only going to see more people trying to numb the pain they're feeling with some type of other. Gabor Mate talks about how addictions are, he's an addiction specialist from Vancouver, talks about how addictions are largely driven by trauma, and how people are trying to numb the pain from that trauma with any type of addiction, whether that's an addiction to wealth and power or an addiction to some type of substance. And I think we're only going to see that more and more as we see these continued economic collapses from the way we structure our economic system. So part of it is that as I try to, in my work, not only talk with patients about this, but also talk with my fellow providers about this, because we don't have time to waste to make this shift. Like I know that people are under stress with work and those types of things, which is we talked about at the beginning of this conversation, but like we need to make this shift. In addition to that, we need to make the shift because I'm sure, as you know, the IPCC just put out that report that we have like 12 years before cataclysmic results of climate change. We're going to see additional health effects from that. We see in California right now, they have, I think, the worst air quality in the world because of all of the wildfires that are going on. So it's not just the direct effect of the fire, and all of the health implications of that, but it's the lasting effects of what happens as a result of that fire. And I think we're going to see more and more of these natural disasters that hugely impact public health as a result of this absolutely insane economic system that we have.
Yeah. All right. So that, you know what, that's a really like doom and gloom kind of way to end. So I'm not going to do that. What would you say is a thing that gives you some hope or some positive sort of outlook on this kind of stuff? Because, you know, it's easy to be doom and gloom and it's easy to be critical of, you know, all the things that we're against, especially when it's a system as bad as our healthcare system. But where is a place that you are seeing some kind of some hope and some real positive vibes?
Yeah, so I mean, I think there are a couple examples that I can provide. So one of which is there's a group that I'm involved with. I think that they do fantastic work. They're called New York Harm Reduction Educators, and I think ultimately, like, one of the reasons why they give me so much hope. So it's an organization that works with individuals with chronic substance use histories, individuals who are often living on the street or in shelters or those types of things. And I think part of it is, from seeing the work that they do and how they're so integrally connected to the community, and having the community actually push back against many policies that they're based in Harlem. So push back against many policies that are negatively affecting their health and well-being. I think that type of activism and that resilience of communities is something that that gives me a lot of hope. I think, you see more and more, especially young people, waking up to how this system is causing the type of suffering that we're seeing actually right after this conversation, I'm going to a discussion in the Bronx about, it's a film that's showing called Asthma Valley. And there are groups throughout the Bronx that have been pushing back against like the gentrification that's happening in the Bronx, the ongoing pollution that happens in the Bronx. And they've been doing it for years, and it's just like that resilience, I think, is really promising. Plus, there's even groups around the world, like in England, I think the Extinction Rebellion that is like getting off of the ground now. So I think like more and more people are coming to terms with the fact that business as usual isn't going to work anymore, and we need to start resisting it. And I think not only in the long run is that beneficial, but also, as you talked about, like the sense of human connection that you gain and purpose that you gain through that type of work, I think is beneficial to individual and public health just in itself. So I think that those things are all really promising.
Awesome. Well, hey, it's been an absolute pleasure to be able to talk to you, and you do have quite a few articles and stuff floating out there. So where could people find more of your stuff, and where can they follow you or whatever?
Yeah, so I've written for Truth Out, Truth Dig, and Popular Resistance. If you just search my name and those websites, normally the articles come up. Like I mentioned, my most recent piece is called Capitalism is Killing Patients and Their Physicians. That's on Popular Resistance. That is a website dedicated to kind of bringing together news from movements all over the country. So I would really encourage people not only to check out my work there, but also check that website out. And then obviously Truth Out and Truth Dig are two great resources for news and analysis, so you can see my pieces there. But yeah, this has been great. Thanks for having me. I really appreciate it.
Yeah, and I had Sarko on a few episodes back, and we were talking about the sort of like race class dynamics and different things like that, and it was a good conversation. But her background's also in public health. So I think it would be good, even cool idea to have you both on sort of at the same time to talk about some public health issues and, consequences of larger capitalist dynamics and the consequences on health. I mean, there's so many different examples, and raising awareness about those so that we can break down that idea that it's, just people making bad decisions as individuals and really a consequence of the system. That'd be good,
That would be fantastic.
All right, man. We'll have to have you back for sure. And it's been a pleasure. I really appreciate it.
Great. Thanks a lot, man.
All right. Thanks, man. All right. Thanks for listening to this week's episode of the Sensible Socialist Podcast. If you like the Sensible Socialist Podcast, you can check us out on iTunes or Stitcher. And you can check out our Patreon page if you want to toss us a few dollars. Don't have to. Don't feel obligated. Just want to let you know it's out there. All right. Got some interesting interviews coming up in the next few weeks. So stay tuned. And thanks for listening. Bye.